Welcome back. Today we are going to look deeper into different types of motor disorders. And so last time we talked about how the brain processes information, how the brain plans for motor movement, and how the signal gets from our motor cortex down into our spinal cord, connects with one of the lower motor neurons that then signals our muscles to contract or one of our organs to function in a way that our heart speeds up or our heartbeat slows down. And today we are going to talk about motor disorders of movement. And so we're going to jump in kind of in a place where we left off a little bit in more detail discussing the basal ganglia. We said that diseases like Huntington's disease and Parkinson's disease were disorders of the basal ganglia. And the basal ganglia help the frontal lobe plan motor movement. That is the purpose of the basal ganglia. The neurotransmitter dopamine is essential for proper functioning of the basal ganglia. And so here what we can see in the blue circles, we're looking at a coronal section of the brain. We can see the basal ganglia, and it's important to note that dopamine is the neurotransmitter that works in functioning properly for the basal ganglia. So that's in terms of us planning, right, our motor movement. And so in basal ganglia disease, so for example, in Parkinson's and Huntington's, these are degenerative processes of the basal ganglia. Eventually, this does degenerate into a disorder of processing or thought, which does result in dementia. But these are called extrapyramidal diseases because it's outside of the pyramidal system. All right, and so what that means is these folks will have certain types of movement disorder where they actually cannot control their movements. So it results in disorders of movement without paralysis early in the disease. So they might have something called a resting tremor. And what this means is often they'll refer to it as pill rolling. I don't know if you can see my hand here, but it almost looks like they're rolling a pill between their fingers and they really can't control this movement. Okay. Bradykinesia means slow movement. People with Parkinson's tend to move very slowly. They tend to have a stooped posture. They oftentimes will lose their balance and they will fall. So they have falls. They oftentimes will end up having difficulty swallowing. And so these are different types of symptoms that you will see in a person with Parkinson's disease. Eventually, they do get to a point where they almost become extremely rigid. And so they do have issues with movement in that they just become very stiff. And so you may have patients that have Parkinson's disease. They may be at different levels of the disease state. And so you can watch for these different types of symptoms in them. Huntington's disease, again, is without paralysis early in the disease. And I had mentioned to you before, it's also referred to as Huntington's chorea. Chorea is another word for dance. And athetosis means snake. And these are uncontrolled snake-like body movements. And so again, these individuals might look like they are mentally retarded or even on drugs, when actually what they have is Huntington's disease. And they cannot control these snake-like movements. And in fact, one of the bigger problems you can have in Huntington's disease is that they move so much, that they burn so many calories, that as nurses, one of our concerns with these patients is their nutritional status, right? Because their metabolic rate is high. They burn up to 5,000 calories, in a day because of this constant uncontrolled movement. In Parkinson's disease, on the other hand, we might be concerned about our patient's nutritional status due to difficulty with swallowing, right? If they have difficulty swallowing, they may eat slower. Eating may not be as pleasurable for them, and we might have more of a difficult getting enough calories into them as well, but for a different reason. Okay, so it's important to kind of be able to differentiate. Okay, so do not confuse cerebrum with cerebellum, all right? The cerebrum we talked about in the last lecture housed our motor and sensory cortexes, right? The cerebellum is this little place kind of in the back, in the bottom. In the cerebrum, so is this part here. The cerebellum is this part down here, and it's involved in balance and coordination. And so this is a different view of the brain, and we can see here our pons, and we can see our cerebellum, and how they are kind of almost surrounding the beginning of our brain stem, which leads into our spinal cord. And so the axons from the primary motor strip run through the pons, right? So in the last lecture, we talked about the axons from the upper motor neurons. They're running through the pons here, and we can also see which is surrounded kind of by the cerebellum. So the cerebellum, the pons receives this information about what the motor cortex is trying to do, and it sends this information to the cerebellum. And so the cerebellum also receives position sense information, so in proprioception. And so when we're intoxicated, for example, it's part of our cerebellum that can no longer do this fine tuning of our motor movement, which is why the officer might ask you to try to walk a straight line. And you may not be able to do that. You may not be able to close your eyes and touch your nose. And so the cerebellum compares actual muscle movement to what the intent was intended by the motor cortex, and the cerebellum then adjusts and fine-tunes that motor movement. And so people with cerebellar disease can have intention tremors, movement disorders, and nystagmus, but usually not paralysis. And so an intention tremor is when you have an intention to maybe pick a coffee cup up off the table, and so your pyramidal motor system makes the decision to send that signal down to the muscles in your hand to reach for that cup and pick it up. And in cerebellar disease, you might have an intention tremor where as you get closer to picking up the cup, the more and more your hand shakes, and it's difficult for you to get a grasp on that cup handle. And so that's called an intention tremor. I have an intention to pick up the cup, and the closer I get to it, the harder it becomes to zero in on. Okay? That's cerebellar disease. So the cerebellum and the pons kind of are around the brain stem. The brain stem, cranial nerves 3 through 12, voluntary eye and mouth movement, also respiratory and heart. So autonomic functions. Remember we said autonomic functions were automatic. We don't necessarily think about them, meaning that our respirations are controlled by this parts of just in our brain stem and our heartbeat. So everything that passes from the brain to the spinal cord passes through the brain stem, including the pyramidal tracts. And autonomic functions such as breathing and heart rate are controlled in the brainstem. So injury to the brainstem is profound, and in many times it's lethal. Because if you stop breathing or your heart stops beating because of injury to the brainstem, you will die. The thalamus is in our midbrain, and what the thalamus does is it receives all the sensory information except for smell. And so we refer to this as kind of our sensory relay station. Remember, in the first lecture, we talked about these places where all that sensory information would come in, and there was this processing center. And so that's our thalamus, our sensory relay station. And so if we look at a picture here, we can see that the thalamus is midbrain. It receives all our sensory information except for smell. And you can see it here circled in blue. So remember, we looked at the basal ganglia before, and now we're looking at the thalamus. And we can see that this is our sensory relay station. So the thalamus actually sends sensory information to all the primary sensory cortex, and it also sends sensory information to the basal ganglia, which then helps the frontal lobe plan motor movement. Okay, so here we see the basal ganglia, and here we see the thalamus, or the sensory relay station. So now we're going to put it all together, and we're going to kind of get to the punchline here. We've studied all of these now. We know that motor control requires a balance between these three systems. The primary motor cortex, which is our voluntary motor control, which comes from our pyramidal tracts. Our cerebellum, which is fine-tuning our control, and our basal ganglia, which has a lot to do with our motor planning. Okay? So motor control requires a balance between these three systems. Okay. So we're going to move on, and we're going to talk about ALS. Remember, we talked about Stephen Hawking, renowned astrophysicist. We said he was able to communicate not by speaking, not by he had very little output, okay? But he was able to communicate by a computer that understood his eye and minimal hand movements, but he was paralyzed due to scarring in his spinal cord, okay? So amyotrophic lateral sclerosis is scarring in the spinal cord. And so A means without, myo means muscle, trophy means growth. So we're talking about no muscle growth or lack of muscle growth. We're talking about the lateral columns in the spinal cord, and we're talking about sclerosis or scarring. So that's where the words amyotrophic lateral sclerosis come from. So remember, we talked about the upper motor neurons that travel from the brain to the lateral columns of the spine. And the red circles here are showing you where those lateral columns are. In ALS, there is scarring of these lateral columns, okay? And so ALS damages upper motor neurons and some lower motor neurons as well. And so ALS is a disease of the pyramidal system in addition to some lower motor neuron disease, but the rest of his brain is just fine. So what he has is a lack of ability to move his muscles, and that eventually includes the muscles of breathing. And so sometimes these people end up having to get a trach and have to go on a ventilator. And what I've done actually is I have taken these 3 disorders of movement, ALS, Parkinson's, and Huntington's chorea, and I've provided you with YouTube links. And I want to encourage you to watch these YouTube links on your own, because if you do, you will get a very nice picture of what each one of these movement disorders looks like in an actual patient. So what we've done is we've studied the disease process behind how their disorder is a result of problems with movement. But I think it's up to you to take the next step and to actually look at some case stories of these individuals online. And then you will have a much better understanding of how the disease impacts their life, how it impacts their daily living, their functioning, and their quality of life. And so I encourage you to go to these YouTube clips and check this out. Right now, we're going to move on to spinal cord injury. And we're going to take a little bit of time to talk about spinal cord injury, because in your nursing career, you will definitely be taking care of patients who have suffered a spinal cord injury. So the first thing we want to look at is that the spine is really divided into 3 distinct levels. We have our cervical vertebrae, our thoracic vertebrae. So we have 7 cervical, we have 12 thoracic vertebrae, and our 5 lumbar vertebrae. And then we have our sacrum and our coccyx. And so in a spinal cord injury, there is paralysis oftentimes, and this depends on the level of injury. Meaning, did the injury take place at the lumbar L1? Did it take place at thoracics in the T6? Was it a cervical injury? Was it a level of C6? Or was it a C4 injury, in which case the person could be completely paralyzed from the neck down? So I want you to take a second to kind of study this slide and seeing that an L1 injury is paraplegia, which would be possibly, the hands and definitely the lower extremities. In a T6 injury, we would be looking at quite a bit of the arms, trunk, and lower body. In the C6, we've got even more paralysis. In a C4, we've got a quadriplegic, where they don't have motor movement in any of the limbs of the body. Okay, and so what I want to talk about is spinal cord injury at the T6 level or above. There's a risk for a phenomenon called autonomic dysreflexia, and you might see this in one of your patients. What happens is, if there's injury of the spinal cord at T6 or higher, it's a condition that occurs after spinal cord injury, usually when the damage has occurred at or above T6. A sudden exaggerated reflex will increase the blood pressure in response to maybe a full bladder or a bowel distension, will cause their blood pressure to rise. So this could be accompanied by a severe headache, bradycardia, which is a slowed heart rate, facial flushing or pallor, cold skin, sweating in the lower part of the body. And so it's significant because it's potentially lethal disorder that occurs in about half or more of the potentially susceptible individuals. It can be alleviated, though. That's the thing. Understanding this and alleviating whatever is causing it can actually be the difference between life and death. So it can be alleviated by prompt recognition and correction of the blocked urinary catheter or other painful or irritating stimulus. And so let's take a look at this slide here. We can see causes of autonomic dysreflexia. So the trigger could be anything sustained stimuli at T6 or below. This can be from an injury to your foot, a blister, from having a full bladder, or a catheter that has been somehow leaned on or blocked, and the urine is getting heavier and heavier in the bladder, causing distension. Maybe the patient has a fecal impaction where they have not had a bowel movement, and again, they're getting distension in their bowels. You could have restrictive clothing, like a belt that's too tight, shoes that are too tight, even socks that are too tight. You could have pressure in a certain area, a broken bone, even anxiety or dehydration could cause autonomic dysreflexia. Okay, so let's kind of take a look at what happens. We're going to break this down so that you have a better understanding of what's going on. So we have a spinal cord injury at T6 or above, and let's say we have a blocked catheter. That whatever happened, that the tubing was kinked and the bladder is filling up with urine because it's unable to drain through the blocked catheter. And so we're getting bladder distension, okay? If this occurs, right, the catheter blockage means too much in the bladder, causing distension, and then the stretched bladder will actually send a nervous impulse to the spinal cord. When this impulse reaches the level of T6, the sympathetic neurons here become activated and release chemicals called norepinephrine, okay? And then what happens is the chemical norepinephrine will cause the blood vessels in the skin and the abdomen to constrict, and it makes the blood pressure rise. Okay? This sudden increase in blood pressure is a medical emergency that can lead to seizures, intracranial bleeding, or hemorrhagic strokes and death. And so in step 5 here, we can see that the rise in blood pressure is detected by the sensors in the heart and in the neck called baroreceptors, and these then send signals to our brain. In step 6, we can see that the brain has 2 ways that it can oppose the rise in blood pressure. Firstly, it sends a message via the parasympathetic vagus nerve to the heart to slow down the heart rate. Finally, the brain sends messages down the spinal cord to make the blood vessels open up again, right? Because the norepinephrine was constricting. Unfortunately, the injury to the cord stops these messages, so only the blood vessels above the injury dilate. This is not enough to overcome the constricted vessels below the injury. And so the blood pressure continues to rise and rise and rise and rise. And that is where the medical emergency comes into play. So again, I'm going to remind you, in autonomic dysreflexia, we have a spinal cord injured patient who has some kind of noxious stimuli, whether it's a full bladder or a belt or piece of clothing that's too tight, that causes the blood pressure to increase. This blood pressure increase cannot be subdued, all right, by activation of the parasympathetic nervous system. And so this dangerously high blood pressure can lead to an intracranial bleed from a bursted blood vessel in the brain, a stroke, and death. And so again, what we want to try to do is prevent this from happening in these patients, or we want to quickly use a relief measure if we can. Keeping them calm if we know that anxiety causes them to have this. Keeping them well hydrated if we know that dehydration may cause this in our patient. A fecal impaction, putting them on a really good bowel program to keep them from getting impacted, making sure that bladder has good flow, right? That there's good flow of urine through the urinary catheter into the bag. We also want to make sure that they don't have a urinary tract infection. That could be another cause. So we want to prevent that if possible. Again, releasing wherever the noxious stimuli could be in this restrictive clothing or some kind of pain stimulus. Okay, so pain, discomfort, and stress. Okay, that's a very important one for you to know about. If you're ever in a situation and you cannot get this under control, you must call 911 and you must get help immediately. Okay, now we're going to take a second and look at upper motor neuron damage. So we've talked about some of the conditions that can damage upper motor neurons in the brain. These are primary lateral sclerosis, amyotrophic lateral sclerosis, a traumatic brain injury from some kind of an accident, a spinal cord injury, again, which can occur as a result of an accident, multiple sclerosis, which is a demyelinating disease, a stroke, and Huntington's disease. So the upper motor neurons, if you remember from our talk earlier, originate in the cerebral cortex and travel down the spinal cord, while the lower motor neurons begin in the spinal cord and branch out into the body to communicate with our muscles. So this is just review. Pyramidal system, traveling axon, through the brain stem, crossing at the pyramidal decussation, which is the beginning of the spinal cord, descending onto the spinal cord and the lateral corticospinal tracts. That's the pathway of the upper motor neuron. The upper motor neuron axon fibers terminate in the anterior gray matter of the spine onto the lower motor neurons, which then have movement takes place, right? That's how our muscle contracts, okay? That lower motor neuron gets that message to our muscle to contract. Then we can stand, we can walk, we can run away from the woolly mammoth, we can, you know, pick up our coffee cup and take a sip of our coffee so we can study harder. So the lower motor neuron then fires, right? And we have muscle contraction, okay? So this is just a visual of that, kind of cement it more into your brain. And so what we want to keep in mind is that sometimes our patients with these disorders can have problems regulating their deep tendon reflexes. So for example, we know in a healthy individual, if you hit the knee with the reflex hammer, you'll get a kick, right? You'll get a deep tendon reflex. In a patient that has upper motor neuron disease, what you might get is hyperreflexia, okay? So what happens is in a deep tendon reflex, it's in a normal individual without any kind of damage, you get a deep tendon reflex that happens at the level of the spinal cord, right? We talked about this with the hitting hammer on the knee. We talked about this with removing your hand from the stove, okay? So we can have sensory neurons that give us messages at the level of the spinal cord, okay? So having these reflexes occur at the level of the spinal cord really allows for instantaneous fine adjustments to our muscle tone to allow for fine postural control, okay? And so let's talk about why upper motor neuron injury results in this hyperreflexia, okay? So we know that the lower motor neuron moves the muscle, right? We've studied that up to this point. We can all agree that the lower motor neuron signals the muscle. Okay, the upper motor neuron signals the lower motor neuron. Agreed? Yeah, we learned about that. We learned about the brain, the motor cortex, and how the upper motor neuron signals the lower motor neuron, which signals the muscle. Well, here's the thing. The upper motor neuron actually blocks all the other reflexes that are trying to signal the lower motor neuron. So in other words, the upper motor neuron suppresses the surrounding lower motor neurons that are attempting to fire as well, okay? So this has to do with homeostasis. It has to do with balance. And so what happens is, if we do not have this anymore, okay, if we do not have this inhibition by the upper motor neuron, what we end up with is lost inhibition, and these lower motor neurons get to fire at will. All right, so if the upper motor neuron is injured, the inhibition is lost, and the upper motor neurons can just fire at will. And so this is why upper motor neuron injury can lead to hyperreflexia and spasticity in our patients that have these types of movement disorders. And so hyperreflexia is an overreactive or over-responsive bodily reflex. So an example of this is twitching and spastic tendencies. Hypertonia is when we have someone who is having a spastic reaction to where they're almost becoming rigid. And this can be very painful. These spasms of the muscle can be extremely painful for our patients, and they need some kind of relief from this. Really, the treatment for this is aimed at symptom control. And so that is why some of your patients may be in a nursing home who have paralysis, who have upper motor neuron injury that get spasticity attacks, will use a baclofen pump, where they can have baclofen inserted underneath the skin. There's a little pump that can deliver the medication directly in during the spastic episode to get it to calm down. That baclofen can be released into the CSF where it can control the spastic movements. So, I hope that this was helpful. I hope that this can help shed some light on how to better care for some of the patients that we have who suffer from neurologic injury. Until next time, aloha.